All right, I think we'll go ahead and get started. We had a few extra folks coming in the back. Good morning. We're delighted to see you. My name is Kathleen Morgan. I'm Deputy Director here at the library. And welcome to our Before You Check Out series. This is a series we have had for, 6 or 7 years or so. And it addresses end-of-life issues ranging from the legal part to the healthcare part to the kind of, I think our last session I called the kitchen sink part, which is just like everything from, making sure that you pass your passwords along to, shutting down your social media accounts, that sort of thing. So the idea is it's a series that addresses all the major issues and at least gets you in the mindset of thinking about this gift that you want to leave your family, which is information about end-of-life issues that are important to you and how you want things handled so that your wishes are honored. So we are delighted this morning to have the hospital here with us, LMH Health. This is National Healthcare Directives Month, I believe, April. The day is actually April 15th, I'm told, which I'm not sure how they landed on tax day for National Healthcare Directives, but they did. So with that, I'm going to turn the mic over to Allison Kuntz, who is our partner in crime over at the hospital in the Community Relations Office, and Allison will introduce our panel.
Hello, good morning. I do enjoy some trivia, so I'm going to answer that question. It's April 15th because there are two things that are certain in life: death and taxes. Okay. There you go. I just had to. Okay, well, good morning. Thank you all for being here today. We truly do appreciate the library. They're a phenomenal partner. We always get to do such creative and fun programs with them, and this one is no exception. So we have an excellent panel up here, and they are full of excellent information, and they're really kind. We were able to meet before and kind of get a plan, so they're really great resources, so please feel free to ask them questions as we go throughout. I'm going to let them introduce themselves, and then we'll get to it.
My name is Rachel Bisick. I am one of the outpatient social workers. A little bit closer? Okay. My name is Rachel Bisick. I am one of the outpatient social workers at Lawrence Memorial Health.
My name is Samantha Dodge. I'm also an outpatient social worker at LMH.
I'm Jody Hitchcock, and I am a social worker. I've been there for many years, and I am now on the skilled nursing and rehab unit.
Good morning. My name's Nicole April. I'm a nurse practitioner with Palliative Support Services over at the hospital. I've been there, it'll be 6 years in June.
Good morning. My name is Julianne. I am the Director and Managing Attorney of the KU School of Law Medical Legal Partnership with LMH Health, and so we've been over at LMH for about 7 years now.
Okay, so we're going to start with, I have a couple questions for you guys. First of all, how many of you already have advanced directives in place? Show of hands. Good job. I'm proud of you. Good work. How many of you have had to make decisions for loved ones when they are in a situation where they are nearing end of life? Okay, very good. So part of the work that we do in palliative support services, so if you aren't familiar with palliative care, we do serious illness care. So we're an extra pair of eyes, an extra pair of hands, really kind of just extra layer of support to help patients and their families navigate through serious health conditions. You don't have to be dying to receive palliative care. We work with patients at any age, any stage of serious illness. Part of what we do, though, is talk about what matters most as we move through a serious illness. And so that's really where the crux of advanced directives come into place, because that helps us document what's most important and then have a documented conversation, not only on a piece of paper, but in our notes, that we've had this discussion with the patient or with their family, or preferably all together, right? Quit working? Okay. It like blanked out for a second. So today I want to start with sort of a very brief review and sort of the conversations that I have with patients and their families about the documents that we use in the healthcare system. And I think the biggest thing that I want to preface this with is that this is a fluid conversation. This is not a one and done kind of situation for the most part. It may be that as your health is good, that you want to kind of be very aggressive in the care that you receive. And as things change for you, you may not want to receive as much aggressive care. And so it warrants ongoing conversation, right? I can't say that 10 years ago, you would want to have the same things done as you do now. And so that's the biggest piece of this to remember. So you guys, if you picked up the handouts at the front, should have an advanced directive book, and then there's a form that's called the Transportable Physician Orders for Patient Preferences. Oh,
If anybody didn't get that form, let us know. I think you have them over there, Kath? Okay. So if you need to either raise your hand and we'll get them to you. Oh, there we go. No problem. Right. Okay. And when we finish this event, we'll email in case somebody doesn't get.
they are also available online. Oh, that's a lot louder. Oh, hello. If you want an online copy, there's a link on the list of links that we put on there. I was just asking if that way you could follow along. Okay, I'm going to keep going. So I'm going to just kind of very briefly review the documents, and then I'm actually going to hand it over to our social workers to talk about the process for actually filling these out. My job is to help you navigate the thought process in filling out the documents, okay? So the first thing, on page 5 of the booklet, there is the durable power of attorney for healthcare decisions. And so that is naming someone or several someones that can step in for you if you become unable to make decisions for yourself, only regarding your healthcare. It's not anybody that's in charge of your finances or any of those things. So the healthcare decision maker, if you become incapacitated or unable to make decisions for yourself, this is who's making decisions for you. So if you've got your least best friend ever, maybe they don't have your best interest at heart, I wouldn't pick that person. Pick somebody that you trust and that you feel knows how you would want to be cared for in a serious situation, because that's who we are going to be calling and saying, hey, so-and-so is having this situation going on. They're not able to make decisions. We need to be able to have conversation with somebody about how things are going. This is who we're going to call. And these guys can say otherwise, I think it's important to have at least 2 people. Because in case the first person is not available, I need a backup. I need somebody else to make those decisions. So that's the durable power of attorney for healthcare decisions. This, on page 7, is the living will. I like to describe this as a very black and white document. It essentially states that if I were to have an incurable illness, something that 2 physicians state will not be fixable, I have a terminal condition, that I wouldn't want to have a bunch of life-sustaining interventions done, and I would want you to just keep me comfortable and allow me to pass away naturally. The hard part about this document is there's two things. So first of all, it's very black and white. And in healthcare, if you have had any experience in the healthcare system, there is a lot of gray. And so we have to figure out how to navigate this. We respect this. We want to use it if it's that time. But we see a lot of patients well before they get to this point. And so then we have to figure out, well, what are we going to do in the interim? How much do we do or how little do we do? The other thing that we run into often is that patients and families think that a living will equates to what is on page 9, which is the out-of-hospital do not resuscitate order. So a living will is not automatically a do not resuscitate order. Those are two different things. So a do not resuscitate order just says to you or to us, if my heart stops and if I stop breathing, I don't want you to try to restart my heart. Just let me go, keep me cozy, wish me well on my journey. And so these are kind of the primary documents that most people will have in place if they have completed them. Now, kind of pausing, does anybody have any questions about that? So I'm going to let these guys talk about that in just a couple minutes. Oh, sorry. I forgot I had to pause.
Okay, I'm sorry, where was the question?
I asked if, when you're designating two people, how do you put it in the form? Do you put and/or or comma?
That's a great question. I usually say or. That way you're not, because if we say and, then they have to be in consensus. And sometimes we'll find that patients will put like all 4 of their kids and there's not consensus, and it just makes it very, very difficult to get the right answer. Okay.
Okay, hold on 1 minute.
Mine was the same question. I'm sorry. Mine was the
Same question, I'm so sorry. Anyone else? Okay, hang on.
Is this all an assumption that a person has arrived at the hospital and has no documentation? Or is this a suggestion for us while we're healthy and here to go home and do this?
I think it's always good to have something started, or at least a thought process started. You don't have to have all of those pieces in place, but I think even, if you're pretty healthy, it's reasonable to have this started and at least have a power of attorney designated as your decision maker.
Okay.
It's good to have this. Can you hear me? Is this working?
I think so.
I'm loud too, so.
We have one more. I'm sorry, go ahead.
Is you do need to have the paperwork in place before it can be used. So that's why we're always asking when you come to the hospital, where is your power of attorney documents? Because if we would have to enact that, we have to have the actual form. We can't just say, oh, they said this was the person. And so that's why it's so critical to get it done and in place with your healthcare providers. If you have an LMH provider, everybody throughout the system can see it. If you go to KU Med Center, they need to have this as well. Because if we have to enact it, we have to have the document, because otherwise we can't verify. And also, if you're needing that to be enacted, then you're not going to be able to fill it out.
I have a question here. I have seen in the past where the person can have everything in place, and all of a sudden, Mary, the dysfunctional daughter, comes in and says, oh my God, keep her alive as long as possible. Is that still the case?
Well, yes. Preferably no, but it does happen. And we have to be careful about how we navigate that. And that's part of why my program, my team is in place, is to help navigate those types of conversations. Because usually that person thinks that mom or dad or whoever it is has been in great shape and they're fine and nothing's wrong. And the reality is that the caregiver who's here in town is watching them fail And so there's always some disconnect. And so we have to really work to make sure that everybody has a broad understanding of where we are in the situation, and then make decisions based on the current information. But yes, ideally, everybody really understands where things are and are able to make a decision based on what's been previously communicated by the patient about their wishes, and then in collaboration with one another. And that's exactly why I say "or" on your sheet, because if there's a bunch of discord, we want to try to have a general consensus, but sometimes we do run into that. So, okay. So I want to go over the TPOP form. That's this piece of paper here. And then I want to talk to you just very briefly about how I want you to think about these decisions as you're considering how aggressively you would want to be cared for. So on this form, this is actually a set of orders from your physician or your advanced practice provider. In the state of Kansas, advanced practice providers, nurse practitioners cannot sign a do not resuscitate order. If anybody has extra time on their hands and would like to lobby against that, I would be more than happy to allow you to do that. But a physician or a physician assistant can sign this if it says do not resuscitate. Okay, so it goes through 3 sections. So Part A talks about whether or not you would want to have cardiopulmonary resuscitation. That's when we do CPR, when your heart stops or you stop breathing. So this only goes into effect if you're dead. Okay, so we walk in, you're not breathing, or we see that your heart's slowing down and appears to be stopping. The standard of care in America is that we initiate CPR. We start doing chest compressions, we put a breathing tube in and put you on life support in an effort to restart your heart and restart your body living again. And so it's pretty straightforward. You either want us to do that or you don't want us to do that. And so that's kind of that first section is, if I don't have a pulse and if I'm not breathing, do I want you to try to do CPR and see if we are successful, or do you want to say, just let me be and let me go in peace? The TV presentation of cardiopulmonary resuscitation, everybody lives, right? Nobody dies. They're always awake and talking in like 5 minutes, and that's just not the case. The reality is that even in a witnessed arrest in the hospital, the vast majority of people do not survive CPR. The other thing that happens is that they are often left in a state, and this is not, there are exceptions, and I fully understand that. They are often left in a state that is very different from their prior level of function. And that's the part that we have to think about, and we'll talk about in just a minute. What matters most as I near the end of my life, or as I'm facing multiple serious illnesses or one serious illness? What matters most? How do I want to be cared for? And what's most important to me as I live out my final days? So that's Part A. Part B talks about how aggressively we're going to treat somebody if they have a pulse and they're breathing. So the standard of care in America is that we kind of throw the book at you. We're going to do all the things that we can to sustain your life for as long as possible. So if that means bringing you to the hospital and giving you fluids and maybe medicine to help keep your blood pressure up, sometimes we have to put you on life support. So life support, we put a breathing tube down your lungs and we hook you up to a ventilator. We think about, if you can't get off the ventilator, would you want to have a tracheostomy? So that's a tube that goes into your neck and provides the ability to long-term support you on a ventilator. We talk about feeding tubes, and we'll talk about feeding tubes in a minute. Maybe that means shocking your heart or doing dialysis. Again, so we sort of have this like smorgasbord of activities that we can do to help keep people functioning. And sometimes it's not always the best thing, and it's not how you want to be cared for. But that is the standard. If any of you that don't already have advanced directives and haven't already had a conversation, walk into our hospital and are deathly ill, we are going to do all the things that we can do to help keep you alive for as long as possible, and intentionally, try to get you recovered and back on the mend. Some people say, I don't really want to do all that. I don't want to be put on life support. I don't want to have a big IV in my neck and have to get medicine to help keep my blood pressure up, but I'm willing to come to the hospital. I'm willing to come in and I'm willing to be treated for things that I can reverse. So let's say that maybe you have COPD and you get pneumonia, or you have an exacerbation of your COPD. So that's a lung disease for those of you that aren't aware. And it just affects how you breathe and how your body exchanges carbon dioxide and oxygen and all those kind of things. And so if you were to have that event happen, say you got pneumonia, we could bring you to the hospital. We'll give you medicine. We can give you some IV fluids. We give you antibiotics. And we watch to see how you do, right? We want to see, okay, are we making good progress? Are we starting to see some improvement in how you're doing? And if you're making improvement, fantastic. What we're going to do is we're going to get you up. We're going to get you moving. We might have to think about some rehab time if you're real weak from being sick. We celebrate that we're making progress. But if after a period of time, we start to see that, gosh, we are just not getting ahead of the game here. Things are just not going very well. In spite of these ongoing efforts to help you feel better, you are just not getting better. Or if we start to see things get worse, if we start to see you declining, we would come to you and we would say, or to your family, and we would say, hey, we were really hoping that we would see some improvement in how you're doing, and that's just not happening. And so based on what our prior discussions were, we would like to suggest that it's this time where we really transition to what we call comfort measures. So we really intentionally make sure that you are not suffering, but we recognize that you are nearing the end of your life, and we want to keep you very comfortable. And we would do that either through management in the hospital. We might consider hospice for you at that point in time. But that sort of kind of depends on how sick you are and how things are going. So that is so B, that would be the selective treatments. So attempt to restore function while avoiding intensive care and resuscitation efforts. So treatment for reversible conditions is how I like to call that. And then other people are like, you know what? I've been dealing with this for a really long time. I know that my heart failure is getting worse, or I know my cancer is getting worse, or all of the above are getting worse. And I don't want to come back and forth to the hospital anymore. It's too much effort. It's too much burden on me to leave my house and come back and forth and receive treatment. And I just want to be kept comfortable. And if that were the case, then we would want to be thinking about perhaps something like hospice for you, so that we ensure that you live out your days as comfortably as possible. Make sure that you're not having pain or shortness of breath or anxiety, depression, all of those things. That doesn't mean that you're going to die within a day or two. It might mean that you live years, but we're not going to keep forcing you to come back and forth to try to sustain your life indefinitely. And then part C talks about medically administered nutrition. So if you're able to eat and drink, we're going to offer you food and fluids. Sometimes, in certain situations, we have to think about providing medically administered nutrition. And medically administered nutrition can either go through your IV, or it can go through a tube that goes in your nose. And then if we need to, we think about a surgically placed feeding tube. IV medication, IV nutrition, and IV fluids, and then nutrition through your nose are considered temporary. Depending on the situation, a surgically placed feeding tube may also be considered temporary. Those have to be in about 3 months before we can even think about taking them out, so it's a period of time. Some people are like, nope, I saw mom have her feeding tube when she got dementia, and it was terrible. She pulled on it. She didn't like it. It made her throw up. She had diarrhea. I don't want to do that. And other people are like, I would give it a shot and see if it helps me improve over a period of time. What we do know about feeding tubes is that it was a really handy-dandy tool when they first started using it. And what we have found is that for patients with chronic progressive illness, they are not often effective at prolonging life. And they don't come without risk. So you're at an increased risk for developing pneumonia. You're at an increased risk for skin breakdown, because often the liquid that we use to feed you through a feeding tube causes you to have diarrhea. You're at an increased risk for infection at the site, or if the tube were to come out, especially in the immediate placement period, you're at a higher risk for that. For getting an infection and getting really sick. So that is the very brief version of this form. And I know it's a lot. I've just thrown a whole lot of information at you.
I'm coming with a mic.
So about this form, when you described the possibilities under B, they were all very nicely contextualized. And so how do I check one when I don't know yet what the context will be when I get there? Is this form used differently from every time? Is there something I'm misunderstanding about how this works?
That's a great question. So I like this. So if you're a pretty healthy person and you don't have a lot of health conditions to deal with right now, I don't necessarily know that you need this particular form. It's really intended for patients who have at least one very serious health condition, and we expect it to worsen over time. So that would be kind of how I approach it.
But the example you ran through, they started with one situation,
Right.
and then they deteriorated or didn't.
Right.
And so the answer to this would change even for somebody with a chronic
Yes.
right?
And so I think the other piece of this, and I'm really glad that they have added section D, which is a blank space, is pick like the most aggressive thing you're willing to do, and then put time limited trial. This is what I'm not willing to go through. Does that make sense? So some people say, you know what, I'm fine with a trial of life support. We know that after 7 to 10 days on life support, we have to start thinking about a tracheostomy and a feeding tube because we haven't been able to successfully get you off of life support. So if we get into that situation and you're like, I don't want to do that, I don't want to be tied to a ventilator long term, and I don't want to be reliant on a feeding tube, I don't want to go to a nursing home to have those things taken care of, then that's your line. That's the line of things that I'm not willing to do. Is that helpful? A time-limited trial, yes. When I talk to patients and families in the hospital, I try to talk about our treatments in the same thought or the same language. We're going to provide a time-limited trial of life support and measures to help sustain your loved one. And we're going to continue to have a conversation with you as we see how things go. And then we will make additional decisions together as things change or as, if they don't improve. We'll navigate that with you. Okay.
And that's why this form requires a doctor's signature. So hopefully you're having this kind of discussion with that person and with somebody like these practitioners that we have at the hospital who are guiding you through that. It's not just a form you want to just have at home and, I'll willy-nilly fill this out today.
And I will say, if you guys are at all questioning or thinking that you need to be having this conversation, have it with your primary care provider. You can have it with your specialist. We are also available to see patients in the outpatient clinic and just sit down. I've had a few patients here and there that'll come in solely to have this conversation with me. And we look at your health conditions and we look at this is what you've got going on, and we kind of navigate what to expect and those kind of things to help with that. Okay, so I'm going to take just a couple more minutes. I know I've got other people who need to talk, but the other thing that I think that is really helpful is, and the thing that I often talk to patients and families about is that we have, again, and I've said this before, we have to think about what matters most as we navigate a serious illness, right? What's most important to you as you are thinking about whatever time you have left on this earth? Sort of like, what's my bucket list things? What am I not willing to endure to stay alive? And one of the things that I think is always a little bit hard is that, we've been sort of taught that we're going to live forever. And I'm generalizing, right? We think that we have all these great tools that we can keep people alive for a really long time. And we do have great tools, but they're not good for everybody, and they're not good for every situation. And so what I will tell patients and families is, we're a lot like rubber bands. And if any of you in the crowd have met me before, you've probably heard my rubber band theory. We're like rubber bands. So you get a brand new rubber band out of the bag and you stretch it and you stress it and it bounces right back to its normal shape, right? But as we age, or as we collect health problems, we're kind of like the rubber band that you dig in the back of the drawer for, and you know it's been there for a little bit and it's kind of brittle, and we start to stress it, and we start to see kind of those cracks and fissures, and it takes a little longer to bounce back to the way it looked before, and maybe it doesn't bounce back the way it was before, and sometimes that rubber band breaks. And that's what happens to our bodies. We have patients that come in that are 95 and they live on their own and they're driving and they're playing pickleball and they're doing all these things. They still have a 90-year-old body or 95-year-old body that if we stress it, it's not going to tolerate that stress in the same way that a younger, healthier body is going to tolerate. And I think that's the thing, trying to visualize that and understand that is always really hard because it is difficult. Well, Mom looked pretty great last week. She was out and about. She was, she went and got her nails done. She went and got her hair done, whatever it is. And yet she's got these underlying conditions that contribute to her poor health. Or, again, just by virtue of having old body parts, we just don't tolerate that stress as well. And so then we think about, okay, because we know this information, maybe we're going to say, hey, I'm okay giving this a little bit of time. I want to see how well that rubber band can get back to shape. So maybe we kind of try to fine tune things as best as we can, and maybe they need to do a little bit of rehab. And we say, we're going to just cautiously watch this. If we're making progress, fantastic, we're going to celebrate that together. And if we're not making progress, then we're going to navigate. And based on the wishes that you guys have talked about, that's where we're going to make further decisions. Does that make sense? Okay. There are a couple of websites, and there's this piece of paper that has the websites listed. There are a couple, so under advanced care planning, there are the 5 Wishes Project and then the Conversation Project. Those are websites that sort of help you think through what matters most with whatever time I have left. So for me, if I were not able to communicate with my family and not able to be out and about and interacting with my children, those are things that I would find really difficult to, and I don't know that I would want to have my life prolonged if that were the case. And this is I go home probably every 2 months and I tell my husband, hey, just so you know, this is not acceptable to me. So it's an ongoing conversation because I see things and I'm like, gosh, I would not want to do that. Or, I'm fine with this for a little while. I'm okay to give this a trial. I want to see how things go. Again, that conversation will evolve, and it has evolved over the time that I've been a healthcare provider. So when I'm 60 or when I'm 80, God willing, that is going to be a different conversation than I have with him today. So that's the thing. So so the 5 Wishes project goes through 5 things. So it's who I want to be the decision maker for me, the kind of medical treatment I do and don't want. How comfortable I want to be. Some people are like, my grandpa would not take medicine when he was dying, like adamantly, like clearly in distress. And he was like, no way, don't give me meds. We intervened. We did. We were like, you can't lay here and suffer. But he was very adamant about not taking medicines when he was healthy. And so we had to really have some conversations about his suffering to help him be comfortable. Other people are like, load me up, keep me cozy. And then how do I want to be treated? How do I want to be cared for? Do I want to try to stay home? Do I want to am I okay going to a nursing facility if I can't care for myself? Those kind of things. And then are there things I want to be sure that my loved ones know? What do I want to communicate to them? What's most important for them to know as I move through my serious health condition? So that's the 5 Wishes Project. Conversation Project has similar information. And then there are links to the Kansas Department of Health and Environment has actually put together a palliative care, statewide palliative care consortium. And so the palliative care providers across the state get together and they help try to advance our services in the state of Kansas. So there's that link as well. And they've got some other resources on there. Okay, I'm going to stop talking and I'm going to let these guys chat.
Okay. I think mine's working. Okay. Hi, my name is Samantha. I'm one of the outpatient social workers And my role is that me and Rachel both, we receive referrals from the primary care doctors and the specialists at the LMH clinics. So if a patient comes in to their doctor's appointment and brings up, hey, I want to talk about advanced directives, I want help filling them out, you'll have that discussion with the doctor, but also a lot of times they'll refer to us to answer some additional questions. We also schedule appointments.
Could you speak into the mic a little more,
Yeah,
please?
sorry, can you hear me? Okay. So we'll also get referrals from the doctors to go ahead and meet with patients to complete the advanced directives. So we'll help with completing the healthcare power of attorney form and the living will form. And so we can meet with you to do that and answer some questions. And then I wanted to talk a little bit more about the healthcare power of attorney. So when we help people fill those out, it's good to make sure that you've had that discussion with the person that you want to assign as your power of attorney so they know what your wishes are. And if you do have multiple people that you want on there, we usually will try to do like a primary and secondary. So that way it's a little more clear on who to go to. And then if you can't reach the first person, then you can go to the second person. There are times I've had people do 3 and do a primary, secondary, and tertiary. And then there's also a space on here if you have any like special requests to add to the form. And then there's a space to put like limitations of authority if there's any decisions you don't want them to be making. So those things are also on there to consider. A lot of times people don't really have anything for that, so we'll just put not applicable if you don't really have anything to add. And that's what we do most of the time. And then on the back of that form is where we have you guys sign as the patient. On here it's called the principal. And then we'll have it notarized or witnessed. So in the state of Kansas, you can either do 2 witnesses who are not related, or you can have it notarized, and Kansas recognizes both. Some other states do not recognize witnessing, so such as Missouri, so they would only recognize it if it's notarized. So a lot of times it's good just to get it notarized, especially if you know you might be going out of state. That way you're covered. So then we get the form all filled out, notarized, and then if we're completing it with you directly at LMH, we'll get it scanned and added to your chart. We'll send it to our records department, and they'll add it to your chart. And then any of the clinics with LMH will be able to see that. So your doctors will be able to see that, any specialist you go to. And then kind of the same thing with the living will, we just get that filled out. That one pretty much has all the information on there, so we just like have it dated and signed and notarized. The DNR does have to be done with your primary care physician. So it's always good to start the conversation with a primary care doctor or a specialty doctor, so that way they're aware of this. And then as social work, we can help you with any other questions or helping you get it facilitated to get it turned in. Are there any questions on that so far?
I'm coming around.
My question is it possible to find out whether LMH has the durable power of attorney already on file? If we think we maybe have done that, but I'm not sure, or does the portal have that information?
I'm not sure about the portal because I don't have access to that, but yes, if you call LMH into the social work department, we can usually look up your chart and see if you already have one on there.
Okay.
Any of your primary care should also be able to look really quick if you're in there to either get a medication adjustment, do a check-in, a quick question of, do you guys have this form? Is it up to date? That's always something that they can very easily look at. And I did want to add, when you provide any of these forms to your primary care office, at that same time you are providing it to the emergency room and to our inpatient and our skilled nursing facility units, all at the same time. They all connect and it comes up right at the top of what we view when we see your chart. So when you are giving it to your primary care, you are also preparing for those extra steps as well. And regarding notarizing versus witnesses, even if you aren't planning on going out of state, I do always add Lawrence Memorial cannot accommodate every single medical procedure. There are some procedures and possibilities where you might need to be transferred to another facility. So we always prepare for those where in the case, if we do need to transfer you outside of Lawrence Memorial towards the Kansas City area, that can get close to the Missouri border, and there are some other hospitals across that border. So if you're ever pre-planning for this, I always recommend getting it notarized however you can, and Lawrence Memorial has some notaries that we are always happy to help get that set up and as secure as possible for you guys.
We have a question in the back.
My question is, someone mentioned earlier that there's not an automatic with information passing to KU Med Center, and since KU Med Center is so frequently used by people in Lawrence, is there a particular system for making sure that if you end up at the KU Med Center, things would get there? Do you know what I'm talking about?
So when you are transferred, that typically comes with either a report, physician to physician, nurse to nurse, transferring you just to let them know about your current care. And possibly if you're already established over there, either through a specialist, we would also recommend providing a copy of this beforehand to any other outside of LMH providers that you're already established with. So when you're transferred, that usually comes with a transfer of documents as well, just any tests that you had, anything that Lawrence Memorial has found on any labs, and typically that includes any advanced directives and anything like that. So in those emergency cases, I do believe we have that method for transfer, but in the cases where, say you're at a specialty appointment at KU Med, and you've had that relationship with that office established for a little bit, I would recommend also just going ahead and giving them that power of attorney as well so they can upload it into their own independent system. And additionally, I do also recommend giving your power of attorney that you are appointing a copy of it and a heads up of, hey, I am appointing you as my power of attorney. We have had some conversations where that's come as a surprise. So communication is always key, and especially in the preparing stage where you are not in any immediate crisis, providing it to the people who need it most. Does that answer what's your question? Okay.
Next.
Hi, so the form is clearly titled Kansas and Missouri, and I'm sure I'm not the only person who often travels to other parts of this country. How well will a document that is put in place in this state be honored by other states?
So it is recognized as a set of orders, like physician orders in the state of Kansas and in the state of Missouri. It should be recognized as an advanced care planning document across the U.S. Because it's still your documented wishes. Most states have moved to a similar form. So they should, I think the vast majority of them have a similar form available. They may not call it the TPOP form. California started this trend. They called it the PULSE, the Physician Orders for Life-Sustaining Therapies. So I am of the opinion that you still have a copy of it somewhere if you can easily access it via email or via your cell phone picture. It still should be given consideration and should be adhered to, even if it's not recognized as a set of orders in that particular state.
Maybe I'm dense, but on this form of the DNR, why does it have a revocation provision?
Because
I mean, if I just signed it, why would I revoke?
People change their mind. That actually happens. I can think of a few people that we've actually had say, you know, I know that we did this in the past, but things have changed. I've given some consideration to this, and I don't want to have this in place anymore. If you do make that decision, you need to let your healthcare provider know so that it can be checked, the revocation, and it needs to be signed, and then we need to get that scanned back into your chart. So whatever's scanned last will supersede what was scanned previously. So if what we have is still a do not resuscitate, and you're like, no, resuscitate me, We don't know that unless somebody's in there with you is saying, no, she just canceled that. She wants to have CPR. We are not going to know that. I know it sounds weird, but, and that same thing. So if you're updating like the TPOP form and we need to adjust it, what is it? Do we put rescind? Yes. We actually put a big line through it and put rescinded, and we initial it, and then we make a new one and put a new copy in.
Yes, does LMH want both the DNR request form on page 9 and the TPOPP form? It seems to be redundant.
Yeah, it is. So, yeah, ideally, yes. If I'm filling out a TPOP and we're making a do not resuscitate order, I will just go ahead and do the out-of-hospital DNR form. I know it seems, I don't disagree with you, but there are some facilities who do not regard whether or not it's appropriate or not to disregard the form. They don't always recognize the TPOP form as a do not resuscitate order. And then for transport via EMS, we have to have the out-of-hospital DNR. We just like to be document heavy, so.
Could you repeat what you just said?
Oh, for EMS. So if you were being transported, say you were going from the hospital to maybe home or the nursing home, if you died en route to those places, they would do CPR unless we have that form on file.
As somebody that works inpatient and on the rehab units and in the emergency department, this is what can happen when you do not have these documents in place. This especially happens a lot in the emergency department. We do have older people, and in most inpatient psychiatric facilities consider that 55 and older. They're called geriatric psychiatric facilities. It's an inpatient psychiatric facility, and a lot of times with the geriatric population, those times are needed oftentimes when somebody has some sort of cognitive process going on and they need perhaps to go through an entire reconfiguration of their medications. And sometimes that requires that specialty of an inpatient psychiatric facility to do that, to get them on the right regimens so that they can be at their facility or be at their home with their caregivers. Without a durable power of attorney for healthcare agent, these facilities now will no longer accept that patient and treat that person without knowing there is somebody to make decisions for them. And so we have had people that needed to have a short inpatient psychiatric hospitalization, and we could not because there was no agent in place. And if somebody's in that state of crisis, they are in no way able to complete that form at that time. Also now, a lot of long-term care or skilled nursing facilities will not accept a patient without knowing there's an agent in place, because they don't want a 96-year-old coming to them who has no agent in place, and then all these decisions of, do you resuscitate a 96-year-old who has 6 different chronic medical conditions going on? And so this is now really starting to affect people's care throughout the whole entire life system. So without these forms, oftentimes we're not able to get you from the hospital to that next level of care that you really need because we don't have this in place. And so that's why I know it's annoying when you come in, and it's one of the things they say, do you have your documents? And then sometimes, and I will take it on for LMH, they haven't been scanned in. And so you're like, but I've just given it to you 5 times. Hopefully we're getting better at that because it really is such an important piece of healthcare. And oftentimes we just kind of ignore that because we're working on this. This is the critical moment you are. But that's why it's so, so important to have these documents in place. And they are, and it is something that we all have to take care of. I've had my documents in place for a long time, but I just had this conversation with my 90-year-old mother who just had her 90th birthday. And for her 90th birthday, her gift to me was she signed an out-of-hospital do not resuscitate order. Because I explained, this is kind of what's going to happen, which what Nicole has just talked about is what does happen when you do CPR on a frail 90-year-old. And she said, absolutely, I don't want to be resuscitated. And so that was our gift to each other for her 90th birthday.
And I know these are not fun conversations to have, but I cannot tell you, and our chaplain had intended to come, but she ended up in the middle of a crisis situation over at the hospital, and so she wasn't able to make it over. But I cannot tell you how many times having this conversation ahead of time before we get into a crisis makes such a big difference in how things go for your loved ones or for yourself. What she said was, when we don't have that in place, it causes a lot of burden. It puts a lot of burden on you as the decision maker, right? If I've already said, don't do these things to me, or this is my line, this is what I'm not willing to do, I have an answer for you. We are going to have the conversation of, Mom said this, and we are now going to utilize what she has already told us, because we cannot fix what is already broken. And we need to honor her by allowing her to die as peacefully as possible. And so Stephanie is our chaplain's name. So that's one of the pieces that she wanted to make sure that we communicated. This is why it's so important to have these conversations. It takes so much burden off of a loved one or a friend having to make decisions. And I'm not here to convince you one way or the other. I want to be very clear about that. My job is to support your goals. So I want to make sure I have it documented. If you want to do all the things and have all the things done, fantastic. Let's do it. Let's see how things go. We're here to navigate that with you. We're going to be right by your side while we do that. And if you don't want to do those things, that's also fine. I have no problem with that either. The other thing is she just wanted to make sure that we communicated that if you are having difficulties kind of navigating these decisions from a spiritual or a faith-based standpoint, reaching out to our chaplain or reaching out to your faith leader is a good place to start that conversation. I know there are some faiths who maybe have a different approach to how they are cared for, what end-of-life care might look like, and there's a lot of questions about that. If I don't do these things, am I committing suicide? Am I doing these kind of things? And so I encourage you, if you have those kind of questions, reach out to Stephanie or reach out to your preacher, priest, whoever it is, your faith leader, to have that conversation, because I want you also to make decisions and be at peace with yourself and with your higher power as you are thinking about that. I'm going to let Julianne talk, and then I think...
I have one question.
Oh, okay.
Well, my question was, if I were admitted to the hospital and I have none of this in place, at what point, and we don't know what's going on, and my family does not live locally, at what point do you ladies show up to say, hey, we need to do X, Y, and Z, if I'm able to speak, I guess?
Yes, that's a great question. So you can always ask for us. Social workers are, so we have a case management team, so social workers and nurse case managers who are assigned to every patient in the hospital. That's Jody's and these guys' counterparts for the inpatient service. My team gets consulted if you've got a serious situation and we need to just start talking about goals, or if we've got symptoms that aren't controlled. We will get consulted, but you can always ask for a palliative care consult as well.
And so I've been purposely quiet. This is not the legal piece of this program. I understand there was a separate piece for the legal part, but I will just kind of reiterate what Jody and several of the panel members said, right? So, and back to a question that was asked, should we do this now? Or now is better, right? Because what happens is what Jody described. We don't have this because we didn't want to think about it, and it is hard to think about. But then you come in and you do not have a decision maker. And so what I do in that process, if I get a referral, I have to file for a guardianship, which is much harder on your family. If for some reason I can't help, you have to go to a private bar. It's much more expensive. You have to go through a court process to name a legal decision maker so that another facility will accept, that patient. And so getting this done now and putting in place what you want and who you want to name, right? It saves, again, kind of the extra burden of a court process later in a crisis when your family is trying to think about, you and your care. Instead, they're filling out legal forms and that piece of it. So doing this now while you have capacity and just making sure, just to kind of reiterate what they said, you can name 2 decision makers. Just be careful and clear what you do. Those conversations are almost more important than the legal part of that, because if you have those 2 people in place and you say, and if they don't agree, you might as well not have this document in some ways, right? Because you're having that discussion and one wants one thing and one wants another. So just making sure how you want to set that up. And I also agree, if you can get it witnessed and notarized. While in the state of Kansas, the law says we give full faith and credit to somebody else's document in another state if it was done correctly. You don't want it to slow it down by another state going, is this right? Is this correct under our law, right? So you just don't want to slow it down. So if you can, doing, at least the notary in both if possible. But the main thing, just, again, if you don't have this in place, we're looking at the guardianship process in cases of transfer.
If I can add one more thing before I think that we're getting to the end of our time. As you go back and discuss with your families, your loved ones, I am of the belief that this conversation should get started from the moment that you can make your own medical decisions at 18. I know that there is no minimum or maximum age on healthcare crises, and I think a lot of people sometimes don't think about it until it gets to this stage. But I believe that it's a conversation that people of all ages should be having. I heard a very moving story at a conference we went to from a hospice care provider whose daughter called her in the middle of the night, who was 18, at college at K-State, and said, I just took my friend to the hospital and they're now asking me if he would want to have his leg amputated if it came down to that, and I do not know how, what do I do, Mom? So unfortunately, those crises do happen. Even just discussing who do I get a hold of in an emergency and anything like that. This conversation is for all ages. We are happy to help all ages with this paperwork or with this conversation. And as you know, as your health progresses, the conversation can become more serious where you start to talk about DNR. I am not saying that an 18-year-old healthy at college needs to talk about DNR and know all that. But as you sort of move through your healthcare journey, starting from the moment of 18, you should know who to call in a crisis and what you might, be moving towards and what conversations you need to be having with your loved ones. So I always encourage this conversation to start from the moment you're 18.
I have a question. I was power of attorney for my sister, and I was unclear how medical decisions were made once referral was made to hospice, because what ended up happening is it was the hospice medical team that was doing the decision-making and not her physicians anymore. Is that accurate? Can you discuss that?
That's a great question. So typically, you have the right, if you are enrolling in hospice care, to elect who is your the medical director for your care, so your designated provider. What typically happens is that all hospice agencies have their own medical director, and unless you specify that you want somebody else acting as that provider, then it would fall to the medical director. And sometimes when you do specify that you would prefer their primary care provider, it still goes through the medical director. So in theory, it should be going through who you designate, but often it just falls to the hospice medical director.
What I found was it seemed like we lost a lot of control in what was going on, and the nurse that was, it was during COVID, which made it more complicated, and she didn't have COVID. But a lot of the decision-making was being done by the person that was attending to her, her nurse that was assigned to her. And so those conversations need to be had, is my
recommendation because it can get confusing, especially she was not terribly old and you know, you didn't know whether it was going to be really terminal, although she was at that point probably, but I wasn't aware of that and it was disconcerting to me.
Sure, that makes sense. And I think the other thing is, you know, if you guys are in that situation and you are concerned, reach out to the primary care provider and say, hey, I put my sister, she elected to go on hospice because she's got this going on. I have concerns about what's happening. Bring it up to the staff at the hospice team. You know, don't be afraid to advocate. You are, you know, you have the right to make sure that you're getting the care that you need, and it's okay to ask, even as we are moving through the end of life. If you have concerns about it, you know, don't hesitate. And that's what I will tell our families. If we discharge a patient to hospice, whether we are seeing them in the outpatient clinic or whether we're seeing them in the hospital, if you have any concerns, call. And sometimes that transition, especially from facility to home, can be really hard. It's really challenging to make that shift and make that move. And so call. Don't hesitate to call and ask for help and say, hey, something's not right here. I have some questions about why we're doing things in this manner, or, you know, that is fine. And if they get offended by it, that's on them.
You can also change hospice agencies. Like if you had like a home health care, you can change agencies. You can do the same thing with hospice because there's different agencies that provide that service. So if you are like really not happy with what they're doing, that may be another option to look at. Yeah.
Yeah, actually going back to the legal person and an earlier question, I'm a little confused around the durable power of attorney. I did hear one comment made about that you could designate a primary person, a secondary person, and even possibly a third person. To me, and then there was a discussion about using or and yet the form has one place for one person. Can somebody clarify? Because I really feel right now, my husband and I are each other's durable power of attorney. I want to have a second person on both of ours, but I'm totally confused.
It's a long line for a reason, so there's space. We just kind of make columns of people.
Yeah,
so
we fit it in there.
They fill it in. They put it on. They put everybody on there. So we make space for it. Yes, absolutely. That's a great question, though.
What she's saying is, so there's this form that's in this booklet is actually a statutory form. Kansas statutes annotated has this particular form there. So if you use this form 1 and 2, you can also, you know, obviously there are some excellent attorneys in this community. If you have one, great. I would just go back to the reason that I've been quiet too. It is very important you work with your attorney, but also your healthcare provider. So your attorney can draft, and so my documents say agent, alternate. You can do 1 and 2. But if you work with your attorney, also work with your healthcare provider, because I've worked with my partners here, and as attorneys, we want to draft the document that you would like, but often medically, we don't have, you know, that skill and understanding. So making sure what you want is, you know, you've had that discussion with your healthcare provider, and it actually makes sense to put it, you know, down on paper that way medically. So you can have an attorney draft it for you. These are forms, templates that meet Kansas law. An attorney can do a different form if this doesn't have everything you need there or enough room, so they can do that for you. Just work with your healthcare providers as well. Does that answer the question? Yes. Perfect, thank you.
And you did bring up a good point, because you're probably around the same age. I never want to go there because you always do it wrong, but that is something to consider, is who is that primary agent? Is it your spouse who's at the same age level as you? And it is good to have that secondary one in case something happens to you and your spouse is not cognitively or physically able to make those decisions, to have that on. That's a very good point.
I'm wondering if there are any agencies, you know, if you're a couple who have no children, you have family, nieces and nephews, everybody's scattered to the winds and not in the area. I mean, who should you be thinking about to take this role if your spouse is gone and all of a sudden you're left alone. Are there agencies that help talk you through that, or do you hire somebody? I mean, I'm just wondering about this.
One thing to consider here in our digital world, you could have a power of attorney that's, actually, I've had one that's overseas. We need that phone number. If we can have communication with that person, then that's what's the important part. So it could be a niece that lives in Nova Scotia, as long as that person is able to be reached. That's the primary thing. And then obviously friends. It doesn't have to be relatives. Our families are consistent of all sorts of things. It's not just I'm blood related to you these days. But as long as somebody can be, that's the important keys. Can we get a hold of that person?
If they're, also if you know that the person you assigned, they ended up moving or they've changed their phone number, then we can also update the form to reflect that information and make sure it's up to date.
And on that note, I will just say be careful about making any changes once these are done. Please consult an attorney or redo it completely. Don't try to make marks on the side, because that could undo the good work you've already done.
As a retired physician who was in ICU work and anesthesiology, I have been confronted by these problems that these ladies have told us about today, and from a physician point of view, it can be an absolute nightmare. So I would encourage everybody to deal with this very seriously. On another thought, something that hasn't been mentioned today, and something that myself and several colleagues when I was working in Kansas City was upset about, was at an end-of-life situation, sometimes you're confronted by a physician or alternate who asks you to consider organ donation. And that can be another situation which is very upsetting to family members. So I wondered if anybody on the panel is willing to address that regarding making legal documents prior to your demise.
You're throwing me hard questions here. Yes, so there are situations in which a patient would qualify and be considered eligible for organ donation. I think that conversation should go along with this. Some people are like, bury me with everything I've got. Others are like, I don't need it anymore. The way the law, the rule in the state of Kansas is that if you sign your driver's license, that is considered consent for donation. Without informed consent, it is consent for donation. So that's one thing that we do run into in the organ donation agencies. They have staff available to help that conversation. It's really hard. We are asked as the healthcare team to not have that conversation, even if we see that that's where we are heading, that person may be eligible for donation. We are not allowed to have that conversation. It has to come from the organ donation team, and so it's really challenging. And I have encountered this. I graduated from nursing school in 2005 and worked in an ICU for a while before I graduated with my master's degree, and it was really hard. It's really, really hard sometimes knowing that that's the next thing coming and not being able to say something. I don't have any great advice other than hopefully you've had some conversation about it. And, if you have questions or you're like, hey, would my mom or would I be eligible for that? Don't hesitate to ask us. It really we don't get to make the final say, but certainly we can reach out to the organ donation team and say, hey, this person is interested in donating tissue, even though maybe their organs aren't eligible, maybe their tissues are. So,
Just to interrupt a second, one of the last session that we have before you check out is what remains, final remains. And we will touch on that a bit, not completely, but we will touch on that because there's not only organ donation, there's whole body donation to a hospital, which we have found out is ridiculously complicated and kind of dicey. But all of that stuff we'll touch on a little bit again in that last conversation with the person that we have who's going to discuss what you would like to do with your physical body at the end. So we'll kind of come back to that a little bit. But personally, we found it's chaotically confusing, just to give you a wonderful thought to go, off on that subject.
And
but
on the
it's
basic
tough.
level, the form itself, they talked about this. There is a place for limitations, and really, when I complete these, that's one of either, I do not want, right? You're prohibited from, do not donate my organs, or maybe for religious reasons, you do not want a blood transfusion. So on a basic level, that form does allow you to give some direction, such as the organ donation.
We have over. Wait.
Hold on. Oh, so everybody can hear.
Did you say if you list two people, they both have to agree before it?
Yeah, it depends on how you list the two people.
Okay.
So, right? And so one,
Okay.
but if you put one first and then one and then two, or you work with an attorney to do an agent and an alternate. So it just depends on how you want them. But again, if you name them equally, then they do have to agree. And as
Okay.
he kind of used
So
the
if
phrase,
I already filled out the form, I had it notarized, can I just put a 1 and a 2?
don't update, you should redo the form if you make any changes on it.
Okay, because I just put my husband and my daughter in case something happened to him, but, okay, thank you.
Are there any other questions? This is pretty important, so I don't want to end this thing until everybody's kind of thought this out. All right, we're going a little bit past time, which is great because
Jack?
this is important. All right, go for it.
Kathleen, is there not an upcoming program that includes legal aid? Is that right?
Here.
No, we did, the first one were the legal implications, and that was with Ann Premer from Stevens and Brand. The second one was the one that Margie and I did, and this is our third.
I thought it was separate from this, not as a part of this series.
That's with the library, that's not with us.
Oh, okay.
Yeah, there is a program in the library that Mark has put together, which is coming up, what's the date? It's coming up soon. It's in the library calendar, but it is not a retroactive program. So sometimes there are programs that are appropriate for retirees and it goes into the same calendar, but it's not ones that we do. But there is a program, it is full. You can go to if you look up the date, you can attend the program, but part of the program at the end is actually sitting down with legal aid, with Kansas Legal Aid or whatever it's called, and doing some stuff, and they only have time to do 20 people. They have enough people to do 20, and I think that's full. However, Kansas Legal Aid, or once again, whatever the name of it is, also, I believe, does regular, I don't know if it's monthly or quarterly meetings with the Senior Resource Center. So you can check with there if you want to use their facilities there to do some of the paperwork here if you would prefer that over an attorney. Nancy's coming around.
I'm getting my steps.
Jack, I'm on the wait list for the next one, and I got an email yesterday stating I could come for the first half hour.
Right.
And then slip out before they did the
Yeah.
20 that were accepted.
Correct, yeah. We're
I
on the same wait list. So.
I think it's May 8th.
Okay,
but
thank you.
The 2nd?
May 2nd.
May 2nd.
Okay, and that's going to be here, and that's done through information services in the library. So, if that helps anybody. Any other questions? Okay, if not, I want to thank our panel. This has been unbelievable. Really informative. I want to thank LMH Health and Allison Coons, who organizes this for us and does a terrific job with both this and gray anatomy. I absolutely have to thank Kathleen, who is the person who created Before You Check Out and reorganized it to do it again. It was great. She did all the labor, so I just have to stand up here at the end and say thank you. So that's been terrific. And I want to thank you guys. We had over 65 people attending today. I know probably another 100 will see this when we film it. When we do record it, we'll send all of you a link. In fact, I think we'll probably send the link, as we've usually done in these programs, to everybody in the organization. We'll try to scan in some of these forms and give you another chance to get a hold of the forms in a scanned form and send that out at the same time. I do want to remind you, besides LMH having notaries, that this is your public library. And we have public notaries here in the library. So if you need something notarized, you know, there's several of them here, including my daughter. I definitely wouldn't trust her if you get somebody named Molly. And one last quick announcement. I'm going to be sending this out today, but if there's any of you in this group that are planning to join us tomorrow at 8 o'clock for the birding session, it has been postponed due to weather, and you'll get an email once we come up with another alternative date for that. You know, the birds can go fly in the rain. We're just not going to go watch them in the rain. So, all right. Is any last questions or anything? If not, once again, thank you guys for coming. If you need anything specifically that you might want to mention to any of the people here, we'll be here for a few minutes, but these people got to get back to work. So thank you for coming, and we'll see you at the next event of Retroactive.